Good morning. This video likes to address a recent publication in Fertility Sterility looking at the use of anti-Müllerian hormone, or AMH, to predict a woman's fecundity. So, just by way of spoiler alert, just a summary of it, these authors have argued that the routine measurement of AMH in young women for counselling them about their fecundity is fundamentally flawed. This practice, still too often recommended and undertaken, may lead to unnecessary and unfounded fears in women whose AMH is low. And like always, a welcome and a disclaimer. My name is James Danger. I'm an embryologist, more than 50 years experience in IVF. These videos are my attempt to bridge the gap between information that you may need for your fertility treatment and the most recent publications available to your clinic staff. I'm not a medical practitioner, and this information is not medical advice, but it may help in knowing what questions to ask about your treatment with your doctor, and maybe to help in understanding the advice that you receive. If so, I hope it helps. And as always, this page is allocated to a potential supporter of IVF Daily. Whilst I'm just starting out, but if you want to promote your company or clinic or product, this may be just the place. So get in touch. It's worthwhile thinking that in supporting this channel, it might mean that an IVF client becomes a better informed IVF client, which is better for all. You can click subscribe or become a sponsor or just make a donation to help others on their fertility journey. Better yet, you can go to my GoFundMe page to make a donation or enroll in some of the Super D modules on my Patreon page. So, do not measure AMH to predict a woman's fertility. There has been some news services recently suggesting that doctors are criticising the use of this fertility test, the AMH test, to predict when a woman may reach menopause. But you might argue in a funny sort of way, this AMH test, which has been around for about 10, 15 years, but is still under some review in terms of techniques, has been commercialised in recent years as a predictor of a woman's fertility age, their ovarian reserve. It's largely driven to consider the aspects of fertility preservation and oocyte cryostorage. But the problem, of course, is that you can get pregnancies from cases with almost no AMH. It is a marker of polycystic ovarian disease, and it is a marker for response to gonadotrophin stimulation used in IVF. But these authors are arguing that it's not necessarily a good predictor of a woman's fecundity and ovarian reserve. So they make the point that AMH is produced by the granulosa cells surrounding oocytes in small developing follicles. The number of AMH producing follicles largely exceeds that of antral follicles, which cease production of AMH. Anti-Müllerian hormone levels generally correlate with antral follicle count at any given time. Both parameters reflect the number of ovarian follicles susceptible to respond to ovarian stimulation with exogenous gonadotrophins, as used in ART and IVF. It's widely accepted that AMH testing aids in managing ovarian stimulation in ART by identifying the women likely to respond either poorly, therefore need greater stimulation, or excessively, and whereby they need to be counselled about the risk of freeze-all. The authors argue that the ability to predict the number of follicles responding to ovarian stimulation has introduced a concept of ovarian reserve. As AMH levels and antral follicle count decline with age, mirroring the decline in fecundity, it has mistakenly been assumed that ovarian reserve reflects a woman's fecundity, the ability to fall pregnant. The simultaneous age-related decline in oocyte quantity and quality has led to the false belief that the two are inherently linked. In reality, their parallel decline is due to a common co-founder, which they say is age. And just to finish off, although age affects both oocyte quality and quantity, these two effects are independent. For instance, if oocyte quantity is reduced because of an age-independent factor such as ovarian surgery or cancer, ovarian quality still remains unaffected. This has been well documented in literature, but I won't go into it here. Some have proposed that ovarian reserve can predict a woman's fecundity. On the basis of this false assumption, recommendations have been made to measure AMH in young women to foretell their chance of future fecundity and predict the age-related decline in fertility, that is menopause. This conclusion is fundamentally incorrect, and they argue using routine AMH testing is inappropriate and prone to foster unwarranted anxiety about infertility in women with low AMH levels. I think that's the thrust of the paper. In summary, they argue the routine measurement of AMH in young women for counselling them about their fecundity is fundamentally flawed, and this process, still too often recommended and undertaken, may lead to unnecessary and unfounded fears in women whose AMH levels are low. But if you look at a couple of other publications, here's a recent one looking at AMH levels in different types of cycles, natural cycles, low stimulation cycles, and conventional IVF ones. They found that AMH is an effective predictor of the number of oocytes in relation to IVF protocol. There's the greater the AMH, the more follicles the stimulation will produce. The number of oocytes increase in protocols including gonadotrophins, but not in protocols with only oral compounds such as clomid. The effect of stimulation increasing with increasing AMA levels was less pronounced. The effect of stimulation increasing with the increasing AMH levels was less pronounced when there was low AMH. So they argued that the highlights of this paper, AMH is currently used to predict their response to ovarian stimulation in conventional IVF. The association between AMH and the number of oocytes in minimal stimulation is not known. That would have been looked at. The results suggest a strong interaction effect between AMH levels and IVF protocols. Seem to be saying much the same thing in all fairness. Oocyte numbers increase with high stimulation dose, particularly when the AMH is high. They're using it to predict the number of oocytes can help to personalise IVF treatment. So when you look at AMH levels in terms of IVF treatment, it works really well. It's a good monitor of the outcome. But if you look at AMH concentration in natural cycles, and here's one published in 2014, where they're looking at time to pregnancy for women who conceive naturally. This study determined that AMH concentration influences the time necessary to conceive a live-born child, the effective time to pregnancy, ETTP, in a population of women who conceive naturally. The time to pregnancy was correlated with age, but not with AMH concentration, although the relation was 0.01, or body mass index 0.5. So, in other words, when you take all the three factors, age, AMH, and body mass together, only age was the predictor for time to pregnancy. The results of this study show, as expected, a decrease of AMH concentration as age increases, but no relationship between AMH and the time to pregnancy. In conclusion, the author said, our study's results suggest AMH concentrations do not influence the time necessary to achieve a live-born child spontaneously, and therefore speak against determining AMH in women who are not infertile for the purpose of predicting their chances of pregnancy. So now, in a 2018 paper from Chinese authors, they saw something different, subtly different, and all these papers, I think, have nuances of the same thing. In their study, looking at timed intercourse, the clinical pregnancy rate was associated with AMH levels, but this trend was not significantly significant. So it was just a trend, so it's either was it wasn't. But you can see that the clinical pregnancy rate for 44%, 41%, and 28% in normal, low, and very low groups there is a trend there. But even 27% clinical pregnancy rate is still good, and it's not infertile. It's not menopausal. The time to pregnancy was longer in very low AMH groups than in the normal group, and the cumulative live birth rate over 18 months was lower in the very, very low AMH group than the normal one, but it was still real, 20% to 60 or 55%. It's only just 0.05, only just significant. The duration of infertility was negatively correlated with achieving pregnancy. So the longer the infertility, the longer it took to achieve a pregnancy. That's kind of logical. So the authors concluded that a conservative management such as timed intercourse with or without ovarian stimulation should be considered in young patients who have very low ovarian reserve, that is lower AMH. However, for women with long duration of infertility or very low serum AMH, then active fertility treatment like IVF should be considered. So just two quick slides on how AMH and follicle size interact. As you should know, there's in the ovary there are millions of primordial follicles which were developed during early gestation, and they spontaneously just start to resume growth, and they form very early primordial follicles, which grow to what they call a small antral follicle with several layers of granulosa cells, and these are growing independently of any ovarian stimulation. But at some point in time, the small antral follicles develop sufficient FSH receptors to bind FSH, and once they start to bind FSH, they grow quite quickly, produce fluid-filled space, the antral follicles, which you can see on ultrasound, and this is the gonadotrophin-dependent phase. But in terms of AMH, these small-growing pre-antral follicles are the follicles that are producing AMH, and the reason for that is that it acts to inhibit the recruitment of more follicles into the growing pool, and also acts to inhibit the FSH binding to these small follicles. And this in a way is a bit like a gatekeeper, keeping the follicles unresponsive to FSH until there is sufficient stage, there are enough receptors for the follicle to be dynamic enough to continue growth, a bit like puberty of follicles. And it's all designed to promote a single follicle growth and singleton pregnancies. So the AMH is produced by the granulosa cells of small growing follicles. It inhibits the initial follicle recruitment and FSH-dependent growth and selection of preantral follicles. But the AMH secreted by preantral follicles as a paracrine factor inhibits the transition of primordial follicles to the primary growing pool, and the estrogen from the first growing follicle inhibits follicular AMH and pituitary FSH secretion, which lowers FSH and makes further follicles growing with low FSH receptors unable to grow. And they ultimately will become atretic and be reabsorbed. In PCO women, this responsive estrogen AMH block is dysfunctional, and that's why you have lots and lots of follicles. From the second growth stage onwards, follicles start to excrete androgens, and these androgens enhance the expression of FSH receptors, facilitating FSH follicular growth and maturation. However, AMH acts as a protective mechanism, preventing the premature follicle selection by FSH. It achieves this by inhibiting both the transition of primordial and primary follicles and the FSH-induced expression of aromatase, thereby blocking the conversions of androgens into estrogens. But once there are sufficient FSH receptors and sufficient estrogen being produced, then AMH is then blocked and these follicles stop growing. So the AMH pool, out of interest, which is the topic of the conversation, is a reflection of both the number of these follicles, which are preantral, and their size. And so the AMH will vary depending upon the number of these follicles that are being recruited. In 2019, the American College of ONG issued a summary statement on the use of AMH for fertility care, and I just read them out. They argued that the serum AMH levels assessment generally should not be ordered or used to counsel women who are not infertile about their reproductive status and future fertility potential. Although serum AMH levels are known predictor of ovarian response to exogenous gonadotrophin stimulation in fertile women undergoing IVF, the use of AMH in women for presumed infertility is limited by the lack of international standards and differing assay methods. A single serum AMH assessment obtained at any point in the population of a woman with presumed fertility does not appear to be useful in predicting the time to pregnancy. The use of AMH levels as a predictor of the onset of menopause is also unsuitable for clinical practice at that time. That was maybe 6 years ago. Currently, serum AMH levels are not part of the accepted diagnostic criteria for PCOS, but I suspect it will be over time. More data on the use of serum AMH levels to predict post-chemotherapy fertility and to guide fertility counts in these patients is needed, and routine AMH testing for prediction of pregnancy loss at the moment is not recommended. In 2025, an article published just last week, you'll find that the nuance from 2019 to 2025 is subtly changed, whereas these authors, eminent Greek authors, they reviewed the role of AMH in ovarian insufficiency and its predictor of menopause, and they argued that the AMH produced by granulosa cells in growing follicles is a key marker of ovarian reserve, reflecting the remaining pool of viable follicles. So this is diametric opposed to the primary authors of the video. In cases of primary ovarian insufficiency, AMH levels are sufficiently reduced, aiding in diagnosis and distinguishing primary ovarian insufficiency with other causes of amenorrhea. AMH levels below 8 picomoles per litre have shown high sensitivity and specificity in diagnosing primary ovarian insufficiency with second degrees of oligomenorrhea. Regarding ovarian aging, AMH declines steadily with age, serving as a reliable predictor of menopausal timing. AMH levels are linked to menopausal symptoms, particularly vasomotor symptoms like hot flushes and their severity. However, its reliability in diagnosing menopause is inconsistent, especially in younger populations or when determining the exact onset. AMH levels can predict an early onset of menopause with limited sensitivity and specificity, particularly when using age-specific concentrations, as lower age-specific AMH levels are associated with an earlier menopause onset. So in a paper in Frontline Frontiers of Endocrinology 2025 in June, this is looking at the AMH levels of a group of women in a hospital environment in different areas. And you can see here that the AMH levels reaches a peak in the early 20s and then just slowly falls continuously up to 45. The correlation analysis revealed a significant inverse relationship with age. As age increases, AMH levels progressively decline. There's no cutoff, it's just a very slow decline. At the age of 36, the median AMH levels fell below 1.2 nanograms per mil. The prevalence of diminished ovarian reserve was 15%, which is obviously the cutoff. What they were saying is diminished ovarian reserve. It was 15% at 18 and 96% by the time of 45. So get back to the original question for this video. The routine measurement of AMH in young women for counselling about their fertility fundamentally flawed. This practice still too often is recommended and undertaken and may lead to unnecessary and unfound affairs in women whose AMH is low. If taken in ad hoc manner, AMH testing may lead to unnecessary oocyte freezing or premature IVF treatment or anxiety. But if repeated at the correct time and with supervision and for other testing such as for FSH, it may alert some women to pending fertility issues and prompt further investigations, but with less anxiety. And with this, I think I'll wind up. Well, thank you for your patience persevering. I do recognise IVF is a personal journey that involves the action of many staff members and many different concepts. It helps to understand all aspects of that journey, and I hope this information may be of value. If you like it, tell everybody else and subscribe to this service. And I'd just like to finish up with one graph. This is the rise in diminished ovarian reserve as defined by the cutoff in AMH. And if you overlook the two together, this is the subject for another talk which I'm working on. You can see that as age increases, diminished ovarian reserve increases, but in reality, this one is a measurement of that, so that's predictable. Okay, I'd like to stop there and thank you for your time.